Hello, everybody. Welcome back again to our weekly webinar. I'm just going to wait a moment. Again, I said some people have had some problems logging on at the beginning. I think it's just a lapse with whole Zoom situation, the broadband width. But welcome anyway. I hope everybody's well and getting back into doing dentistry, and things are finally coming to some level of normality anyway. They are for us. Today we're going to be starting a four-part format rehabilitation, whatever you want to call it, Teeth Express, all on 4, all on 6. Regardless, the principles are pretty much the same. So that's what we're going to be talking about today. What I am going to be doing in a moment is just going over a couple of things that are now in place. Apologies for it taking a while for us to get the webinar, the boot camp organized, but things are now organized with confirmed date, largely because of the situation, the current situation. It's taken a while to actually confirm dates. But without further ado, I'm just going to start our webinar. Okay, so the boot camp, as I said, is confirmed. It is now, confirmed for the 5th and 6th of February, and it is. Oh, sorry, a bit of a technical issue there. Let's just come out of there. Okay. Sorry, let's just start that up again. Okay, so the boot camp is basically the 5th and 6th of February, and it is, we're having a bit of blinking here. It's just freezing a moment. Give me just a moment. I'm just going to come back out of this. I'll come back in. We seem to be having a glitch. Let's try again, shall we? So as I said, it's on the 5th and 6th of February. It's 2 attendees for $595. That's 12 hours CPD. You can contact us on the email hello@drbobbychhoker.com.au, and also you can give us a ring at 8070-9010. And get yourself registered. It's the $595 for one person or $595 for two, but obviously we encourage you to bring someone because then it's half the cost for you, and it's pretty good to get sort of that much information in a whole weekend, along with having 12 hours CPD. Also, what's new on our website is a For Dentists section. So if you go over to our website, drbobbychhoker.com.au, it will have things for dentists, including links to webinars and a multitude of other things. Okay, so seem to have this little glitch here of bear with me. Okay, I hope everyone's hearing me loud and clear. We're going to start with the Teeth Express, the full mouth rehabilitation. We're going to go through some of the the need and the history behind this, because there's a bit of there is a bit of there's a little bit of controversy about the fact that we are, sorry, going back if people haven't seen it, a controversy about this, whether it's all on 4 or whatever you want to call it, that, you know, whether it works, whether it's all on 4 or none at all on 3, but that's not exactly how it works. I'm going to go through that today. So a little bit about me for people that don't know. People who have been attending the webinars, I'm sure you do know. that's basically my background. I am now also teaching the master's degree, the diploma, and the certification in implant dentistry, which is an accredited qualification. So this is what we're talking about today. Basically, changing paradigms in implant dentistry. We're going to a bit life expectancy, treatment longevity, edentulous patients, implant-based solutions, barriers to treatment, dentist influence on the outcome, and the solution, really. Okay. So ultimately, you know, this usual way of placing implants with individual ones was delayed placement, and there's a lot of grafting and healing prior to placement. So patients coming in where they needed a full clearance would often have to have grafting, use of a denture for at least 6 months, come back, possibly further grafting, and then placement. As opposed to, you know, we had delayed loading, because you place the implants, wait the 3 months still with the denture, now at 9 months with the denture, and then load. They then progressed into sort of single implant immediate loading protocols for a single tooth, and ultimately full multiple tooth, and then full arch. In Australia, life expectancy of someone born in 2011, 2013 is 80 years. And it's expected to go up to about 85 years. Australia has a higher life expectancy at both male and female level than many similar countries such as New Zealand, United Kingdom, United States of America. So when patients come in, you know, it's about quality versus quantity, you know, and it's quality of life. And as I said, it says here that my oldest patient that I've treated with a full mouth rehabilitation was 88 years old. And she's a lady who loved going out, enjoying dinners and luncheons, and she felt that she wasn't doing that anymore, and it's important to her. And quite rightly, she said to me that, you know, it doesn't matter how long I am around, I've lived for many years, that, you know, it's every day that I enjoy with my team. And that's basically CEO of the business side of the life expectancy going up. So the evolution of concept of angulated implants in dentistry, there's a 14-year clinical trial, good paper to read, 3,101 implants with an observation time of 10 years. So it's not like something new. This study's, you know, 2002. So, you know, we've had a fair bit of background data on it and found that most cases can be completed successfully. And there is a 97% implant success rate. I think, you know, obviously the mandible tends to be a higher success rate because of quality bone as opposed to maxilla, but it's very negligible between the two. So 2/3 of patients we treat at practice full arch restorations are soon to be dentulous patients. Okay, existing dentulous versus partially dentate patients. Now you all have managing software, and if you've been charting your patients, it's very easy for you to do a search for patients that are either edentulous or at least partially edentulous for small span implants, single implants. It's an easy way for you to start, you know, marketing your dentistry with spending really no money at all. And it has proven longevity, as I said before. The All-on-4 is a noble trademark. You know, that's not the only way of doing it, but this study is just, I think it's a noble funded study. And, you know, so mid-term 3 to 4 years was 96 to 100%, and long-term 5 to 10 years was 94.8, 95 to 98%. There are stable bone margin levels, healthy soft tissue, both the tilted and axial implants, because a lot of the time people talk about the fact that the tilted ones cause problems. And it shows that the survival rates are similar. There's a number of studies, and I'm happy for anybody who's interested to send you these. If you're interested in reading the papers, some people are, some people are not. I do encourage you to do so, but you should also learn how to statistically analyze a paper. So with the medical statistics is important because you don't want to be reading paper, the abstract in itself, and how the trial was conducted, and the cohort in itself should tell you whether or not you really want to carry on and read the paper. Quite often you can omit papers very quickly if you know what you are looking for, and the list goes on. Okay, so this says in the next 5 years, the global market implant supported full mouth prosthesis is estimated by 6%. This has actually gone up, and mainly due to baby boomers, great increased life expectancy, and more people with dentures population, because you're really treating people from the past that have had a different level of dentistry and have, you know, been to probably types of dentistry where it's heavily filled and the access has been less. Okay, and market growth will go on, and that was to 2020. It's actually gone up further from there. So what we're going to do is introduction to the techniques. We've gone through a bit of the popularity, how to do a case assessment, treatment planning, surgical protocols, prosthetic protocols, risk assessment, informed consent, and case presentation. Now, I know I've covered some of this in the past, particularly maybe informed consent, but I will go over that specific to a full mouth rehabilitation. Today, as I said, it's 4-part. We won't be covering all of this in one part. We're covering the first 2 segments, and the rest we will then sort of elaborate on the remaining 3 webinars. So, case like this, for example, somebody coming in, I mean, this one's a fairly obvious one because you can actually see that most of the teeth are terminal. The teeth at the top, heavily restored, bone loss, all the restoration on the top have, you can see deficiencies. The lower, pretty much the same, with the remaining intact teeth having very little bony support. So, you know, a number of things that people would, in the past would do, you know, if you wanted to get the bone back where you needed the implants, if you need sinus lifts or bilateral sinus lifts, on-ray grafting. Distraction osteogenesis, that's where basically a segment of bone is cut away from the main body of bone, and that's fixed with a small gap, and that's distracted upwards, and the bone follows to create height. Is probably the only scientifically proven way of consistently getting bone height as opposed to grafting. Not to say you can't go grafting bone height with grafting, but it's probably the most predictable. But I don't know many people that will go through as a patient distraction osteogenesis, and I don't know many dentists that are skilled enough to embark on it or would want to embark on it if they are skilled. That's something, if I really wanted to do, I would, now at this stage of my career, probably refer to my Max Bax, Weber and ask him to deal with that. Okay. Delayed implant placement and delayed loading is discussed. If we're a denture, there's always second stage, then a final prosthesis, and time was about a year with multiple procedures and healing and hence compliance. So it doesn't really matter whether you're placing 6 implants or 4 implants, you know, we will talk about that. It's about spread. By the way, this is represented with obviously template of BioRisers and Henry Schein, and they originally gave these lectures and ran, of course, for full mouth rehabilitation for those companies. And this is some of the material from there, so that's why they're so they're cost efficient. It's a graftless solution. It's either 4 or 6 implants. You get a medium function with 12 teeth in most cases, not always. You can have then delayed function of 12 teeth. Sometimes we have less than that because the spread is not great and we've got a cantilever towards the end, so usually we have a smaller bridge while the implants are integrating and then convert to a bigger bridge. Working on evidence-based dentistry, realistically, you don't really want to exceed a 14mm cantilever. It's predominantly graftless. What I mean by that is essential grafts. When we place the implants, if we're doing an alveolectomy and harvesting or leveling out bone, we harvest that bone. And what we usually do is if there's any residual smaller ends of sockets after alveolectomy or any areas around the implants in particular where the buccal area is thinner, or the lingual area, we'll graft that into there because it's precious bone, we don't waste it. Increased bone contact by length and tilting. You avoid vital structures, but in particular the sinuses, and on the lower, the mental foramen. And you engage, and also the ID nerve, but you engage better quality bone by cortical fixation. We will go into that later. and you use multi-unit angles and heights to basically upright the tilted abutment interface. And torque is always key, as it always is with implants. So moving forward, that's basically an infographic of the basic process. So in this case, it's another case, similar sort of situation, although there's not as much bone loss. These teeth were all non-vital, heavily filled, largely terminal. Look, you could, one of the things you could have done here was at the upper, not so much, you've got the 1-3, which is decayed and pretty much terminal. But if you wanted to, you wanted to really go in and the patient didn't want you to remove those front 3 teeth, you could, in this case, possibly root canal, treat those teeth and recrown them, and then place implant bridges on the upper either side. The lower, you could do pretty much the same, bar obviously the decoronated tooth. But however, this is where you need to give the patient options. In this case, that's what was basically there. That's what you see in the X-ray. The oral hygiene at this point prior to treatment wasn't great, and we have quite a strict regimen and protocol, making sure patients are up to scratch with that, because you don't want to put a fixed prosthesis in their mouth and they end up in this situation a few years later. We always look at possibly converting from a fixed prosthesis to a fixed rule, as in a implant retained denture in these cases, and then so they can take the denture out and have better access to the connections and clean them, and later move to a bridge if that's the case. This doesn't happen very often because we're trying to be really on it in terms of teaching and motivating the patients, and we have like a good 2 long appointments where they go through with the hygienist all cleaning protocols and a regimen for them to adhere to, so that we can then assess that again and see that their oral hygiene is of a standard to place the implants. There you can see decay in the same. They've been splintered at the top because they're moving, all that crown is about to go. And on the other side, it's pretty much the same with the decoronated tooth as well. On the upper, you can see again the blood accumulation. I presume this patient slept with their denture in, because you can see a certain level of denture stomatitis developing there. And on the lower, you see very flat ridges at the back. There's not a lot of bone to be placing implants posteriorly in a conventional manner. And there are the dentures. As I discussed before, we'll cover things again. You can tell a lot by a denture. You can definitely tell that the amount of tissue that's missing, because a pink is really replacing bone and soft tissue, or really bone. The soft tissue is overlying the bone, so it's a good indicator to see loss of bone in the area prior to even taking an X-ray. So that's basically where we started. That is where we ended up. And there are the upper and lower. I think those are the provisional prostheses, and those were the final prostheses, which wasn't a bad result. You can also see that, on the corners of the mouth, and they had angular colitis from the dentures that she was wearing. It largely got better. It was a lot worse than that, but it was slowly sort of getting better, and it's obviously having that vertical dimension and no loss of vertical dimension, and re-establishing that allowed that to eradicate that. There we are. Okay. Well, ultimately, what's happening is that you get the bony changes and facial changes and resorption of the mandible and the maxilla. And, this is what happens with the dentures. Wolff's law is very good, developed by German anatomist and surgeon Julius Wolff in the 19th century, states that a bone in a healthy person will adapt to the loads under which it is placed. If loading on a particular bone increases, the bone will remodel itself over time to become stronger to resist the sort of loading. The internal architecture of the trabeculae undergoes adaptive changes, followed by secondary changes to the external cortical portion of the bone, perhaps thicker as a result. The inverse is true as well. If the loading on a bone decreases, the bone will become less dense and weaker due to the lack of stimulus required for continual remodeling. And that's, as you know, what happens if you remove A tooth, the area remodels. There's no load on it. If you replace it with an implant, you're maintaining that load. So need to maintain bone will store 25% and 4 millimeters lost in the first year. Okay, that's what tends to happen when you take teeth out. On average, aesthetic and functional impact, you get quality versus quantity of life, and implant supported dentures versus bridges and related happiness. Okay. Also, dentures sort of don't create the same load within bone. It's on top of the bone, and in some ways accelerate the bone loss. So, this is maxilla mandible. You can see that there's no resorption, mild composite defect, moderate composite defect, and advanced defect. In the advanced defects, where there's insufficient bone for full mouth rehabilitation in this manner, usually patients have the option of either a denture, implant retained denture, or zygomatic implants. So the popularity has increased. It's basically mainly reduced. It's increased aesthetic sense of speech and self-esteem, and potentially it's a life-changing treatment. It is for me, for patients that have this done. I'm very happy to say that I do see people completely change and grow, and it's very easy for us to forget that as dentists. And putting, I think a good clinician tries to put themselves in their patient's shoes even for a minute to think what things are like for them and where they are now, where they want to be. It reduces the treatment complexity, number of surgeries, overall time. And also the tilting of the implants stops you having to do that time-consuming bone grafting procedures. And you have immediate loading with a fixed provisional prosthesis, which shortens from time to teeth. Okay. And ultimately, it becomes lower costs. On average, if we were to do it in a conventional manner, I would say it's almost double what we would charge for a full mouth rehabilitation. Practice without diagnosis is malpractice. So diagnosis is key. Although every dentist may have a different treatment, we all need to come to the same diagnosis, and this will be based on information collected and hence treatment protocols and predictable outcomes. So treatment planning, the maxilla. See the amount of hard and soft tissue remaining. Facial and lip support, smile line, lip length, bridge display during smiling, the bone quantity as well as the quality, the tissue thickness, the tissue biotype, and also the bioform. And I mean sort of the shape of the teeth, whether they're rectangular, square, oval, round, length of the teeth. So the amount of hard and soft tissue remaining. Support of the lip is provided by the cervical contour of the central incisors and the alveolar ridge shape. When these teeth are extracted, we get cranial and medial resorption of the maxillary segment. That's important. A lot of these patients, you see, have a very draped lip, wrinkles around it, and they tend to get that curling of the lip. Depending on discrepancy, dictate treatment. Mild conventional is crown and bridge treatment on implants. Okay, so you're going direct to fixture. Moderate to low profile prosthesis, so moderate to low profile prosthesis and extensive is all on 4 teeth express, one if you want to go teeth in a day, and severe is zygomatic. So these are sort of the two sections that tend to accelerate. The continued presence of denture accelerates bone loss, of structural support of the face, and soft tissues. The lower third of the face is dramatically smaller. Making the appearance more aged, so its heads curl up and what they call nose to chin. That's normal anatomy, begins to recede until you get continuous without intervention. And those are the main areas that you will see the bone changes in. You will see in the nosy and the zygomatic areas and the anterior maxilla and definitely around the teeth. And quite often you're ending up with something similar to this. And this is not uncommon for patients to come in and see me and see this type of thing. Now, look, you could treat it conventionally. There's just a schematic of showing, just some basic plan to show that, what not to do. We need to make sure we know where the maxillary sinuses are and map those out. As you can see in this case there, they are pneumatized and they've they're quite large, because when there's a lack of teeth, the sinus grows down and the bone resorbs up, leaving a very thin area. And posterior, the mandible has become thinner too. But we're mainly interested in that bone in that central area, either side of the sinuses and either side of the mental foramina. Although on the lower, if there's bone beyond the mental foramina, you can add additional implants, and that's usually where I look to use 6 implants to get a better spread. And there you see it from the side view. On the low, you can see how thin that mandible becomes. On the ridge, you could round that off and go down to more of the basal bone. Here at the top, you can see there's virtually no space towards the back. Anteriorly, you've got about 12 millimeters. Yes, you could place an implant. You could use osteotomes to expand that bone. But as it gets further along, it gets harder and harder. And although it says like at the bottom 10 millimeters, I would not be wanting to place an implant in that situation. Somewhat compromised. Patient again with dentures, full complete upper denture and partial denture on the lower. In this case, a very sort of procline profile, as you saw in the last X-ray. That's the patient's profile on the X-ray. And the initial X-ray you saw, splayed teeth, movement, no teeth on top with quite a flattened ridge. That poses its own problems, even for you to have a denture. And excuse my dog barking in the background. That is how she presented. Okay, with the procline teeth. That was partly because actually position teeth, not just splaying. This is where we ended up. The upper teeth and upper implants were placed at an anterior angle so that we could actually make sure that the prosthesis was in the right place. So how much restorative space do you need? It's 10 to 12 millimeters for conventional, 12 to 14 millimeters for low profile, and 16 plus millimeters for an overdenture. Ultimately, we have we mount the alveolectomy line 5 millimeters above the smile line, and then beyond that, you need to see how much bone you've got left to the nose. In some cases, with patients with a very high smile line, you know, all on 4 is not possible, because by the time we do the alveolectomy, so that they can't see the prosthesis, that transition line, we have very little bone to place implants. So, you know, the actual distance taken from the head of the fixture, and you need to make these considerations, as I said, for the smile line and the alveolectomy. The remaining height of bone must be weighed up against these measurements, and that's exactly what I said. You just need to see how much bone is remaining. So again, you know, going back to that, that's basically what you need to have a look at. And when we perform a maxillary full mouth rehabilitation, there's anterior implants. When we retract the tissue, I will go back, I'll actually retract up to the base of the nose and feel in there surgically to see that we've got to the tip of that, so we know exactly physically and visually where the base of the nose is and the dip into the nose. So treatment planning for the mandible. Measuring the denture's jaw. This can be sometimes difficult, because if you have a patient that's wearing a denture, it's very easy if that was a patient's teeth, and let's just say they're all periodontally involved and we need to remove those. We know that that's a smile line. Usually I'll get the patient to do a really exaggerated sort of Gary smile, so you can see where it goes to, and use that more of a marker. Okay, and if we're left with very little bone above it, then we try and go somewhere in between. But when you've got a patient who's wearing a denture and they're smiling, you need to find out exactly where that smiling line is and be able to measure that, okay, because you no longer have the teeth as a reference. Here again, you know, when it's smiling, can't see any of that ridge. Okay, is that great? But you may find that the actual ridge is just below the lip. And you see with the denture, it's quite a chunky and hefty denture. But when you take it out, there's not a lot there, and I wouldn't be concerned about this. In this situation, I would probably be doing no alveolectomy at all, because it's been done for you naturally, and the transition line would be hidden under the drape of the lip. So positioning of the central incisor edge, the vermilion border, F sounds, golden proportion, repose at 1 to 2 millimeters, 50% of the tooth showing at ESAND, and reduced arch and and you only need to take on board patient requests. Ideally, we try and get sort of 16 to 17 millimeters from the head of the implant to the tip of the incisor. That's what we're looking for. But that's not completely true depending on what you use. Things have progressed a bit and you've got leeway, but if you take that as a marker, then everything from there is safe and you have more adaptability and flexibility. This patient is periodontal disease, moving teeth, missing teeth, as you can see there. And again, a very deep overbite. There's alveolar compensation there. Biotype 2, I'd say the bioform is somewhat triangular. And you can see the buccal bone loss from the loss of teeth, which is fairly significant, particularly in the sort of 1, 2, 2, 3 area and the lower premolar area. You can see it dips in quite significantly, and this needs to be taken into consideration. With the alveolectomy, you'll find that you lessen that, but you need to take that into consideration because you're going to be prosthetically driven, and your implants are basically going to support that prosthesis, and you need to place implants to meet the occlusal load. So you need to have a look also if there's, you know, any form of parafunction. So most elderly patients require lip support, provide the labial flange overlay denture, particularly if they've been wearing a maxillary denture for an extended time period. Where this is extreme, we tend to try and move the prosthesis somewhat forward. It needs to still be cleansable. You don't really want a big ridge at the transition line. So you need to actually consider this too, because otherwise you'll get the teeth, but you'll still have this area that is not filled out. You need to be careful that you're not encroaching on the neutral zone, and you need to have some basics of occlusion to know at least where the setup, and with the help of your technician, you should, and some more advanced occlusal analysis and some mentorship, you'll then know exactly where you should be placing that. There's patients, the upper and lower implants, and things are there at the smile line. We've probably got, with the smile, we've probably got roughly just slightly over 50%. Obviously, this varies, you know, with person to person and the architecture of their face, and particularly lips and the mouth, the philtrum and the surrounding tissues. Yeah, from the side, I think that's quite a nice aesthetic result. Better picture there. And there's the upper and lower prostheses. These are provisionals, again, not final prostheses. So you want to get, obviously you need a CBCT, and the way that we plan this is that when patients come in for their first appointment, when they've actually committed to treatment, we take scans, upper and lower, including the bite. We take a CBCT and we map the two over each other. We then plan where we're going to be placing implants. I'm not an advocate of doing full mouth rehabilitation. We are guided, regardless of what anybody says. I've tried and tested a number of ways, including stackable guides, etc. And they work for very easy cases, but most of those cases you really didn't need the guide in the first place. It's more the prosthetic part. Some people use a drop denture. We tend to measure and place our implants according to that, and we have markers, and we place with those angulations, and we use things to help us during the surgery to get the correct angulation. And if we know our starting point and we know where we want to put, we have our angulation, the implant will then, by angulation and starting point, end up where you want the tip to be. You have in cases where you're having a proclined ridge at the front, and also the occlusion is sort of proclined naturally, you want to angulate the anterior implants rather than straighten them. Sometimes when we only have bone to put straight implants in certain areas, and they're actually naturally proclined and we don't want them to, then we do the reverse, and we do that using the multi-units. We're going to place them higher up, and again, planning top down, building bottom up. You know, that's what I mean. You want to be prosthetically driven, so you want to know where the tooth is and where it needs to be. Okay, the transition line, that's the green part there, is apical to the smile line in red with an aesthetic outcome. As I said, we usually make that for 5 millimeters is our usual rule of thumb. As opposed to it being coronal to the smile line, and you get an anesthetic outcome where patients smile and they can actually see the transition line, and they're usually not very happy about that at all. So, you know, that's one of the things that's always needs to be on your mind that you're going to be doing. Bone quantity, OPG with little bone height, maxilla, pneumatized sinuses. You know, if you take OPG or say CBCT, need 5 millimeters width, 10 millimeters height maxilla, and 8 millimeters height mandible due to its density. In a 5 millimeter width, you know, now it's common practice to say that you need a millimeter of a layer of bone along the implant. You know, I would encourage you to try and make sure that's 2 millimeters, you know, as a safety. With the cone beam CT height and width of bone, upper and lower, you need to check where the sinuses are, the mental foramina, distance between the sinuses, so you see what spread you're going to get, because that determines where the access holes for the implants are going to be based on the bridge. And ideally, the standard way is I've tried to get them through the sixes and the lateral incisors. That's not always possible, so you need to consider what your anterior posterior spread is going to be, and whether you can utilize bone further back, whether it's beyond the mental foramina or towards the posterior part of the sinuses. And sometimes what you can do in those situations is use the tuberosity and tilt the implants rather than forwards in front of the sinuses. You can tilt them backwards behind the sinuses, and that gives you more implants to get a better spread. You also need to check for any pathologies if you want to remove them. Anything near implants, even if it's not right near, you know, it's very easy to grow to something sterile and soft tissue, and these pathologies grow faster than bone does, and they inhibit the bone loss growth. And very importantly, you need to check for the anterior loop on the lower. On the upper, if you're using, which you'll see later, what we call a pin drill, which is very fine, about 1.5 mil, and you have it managed to sort of go into sinus, that will actually spontaneously close and heal itself. So, you know, you get a chance to move forward. You don't really want to be there, but when you're trying to get close to sinuses, this can happen. It happens to me, okay? With the lower, you don't really have that liberty, because if you have an anterior loop, you need to check for that. When you're angulating forward in front of the mental foramen, you need to make sure you're not impinging on that anterior loop. One of the other things I get asked about is, well, how deep can you go with those lower anterior implants? What about the incisors now? And my reply is usually, if there's no incisors, then you're not really concerned about the incisor nerves. I wouldn't intentionally try to sort of drive the implants all the way through. But you know, you need to be respectful of that. But if that needs to be used, then you would be able to use it. You know, this is the type of situation again that you commonly get. You can see there's alveolar compensation in the mandible here. This is to your advantage, because ultimately it's put bone where you've wanted it. So in these cases, it's quite an advantage to have this. You just need to check the quality of the bone. You see the foramina are quite close together, and there is a slight anterior loop, particularly on the lower right quadrant. On the upper, anteriorly, you've got some fairly decent bone, but where you want to place those angulated implants in front of the sinus on the upper left quadrant, it's not terrible. We can probably work with it, but on the right, there's not a lot. And what would you do in these cases? In these cases, I would probably look to placing an implant further back on the upper right quadrant. I would still use another implant in that area, or alternatively, I would have the provisional prosthesis on the 4 implants and add another implant in the area for the anterior posterior spread. There you can see the width of the mandible, very thin, extremely thin. And you know, it's quite a big difference to what you're actually seeing there. So that's why CBCT is so important. You can see that's pretty thin even once you've taken them down. Now you could make the argument that, look, you know, if we removed some of that bone and the alveolectomy was a bit bigger, we get to a wider area of bone as you're getting towards the basal part of the mandible, and that could be used. If you have sufficient implant length to support the increase in prosthetic height, then yeah, that you can do that. My preference would probably be in this situation to place the implant, augment with bone onto the buccal, put the patient into a denture for 3 months and come back and do it as a 2-stage. Coming back again, there's the maxillary slices. As I said, anteriorly, it doesn't look too bad. It's not, you know, it's a little bit patchy in certain areas, but it seems to be plenty of bone in that area. Okay, so I'm just going to end today with the Bedrosian scale. And basically, this is the 3 areas. It's 1 is a premaxillar canine to canine, 2 is the bicuspid region, and 3 is the molar region. Scenario 1, 5 millimeters width, 10 millimeters height, all 3 zones, place as many implants as required conventionally. Scenario 2 is 5 millimeter width and 10 millimeter height, only in zones 1 and 2. That's the anterior zones of bicuspid anterior area, and you look at placing, you know, conventional 1-on-4 style teeth expressed in their day style implant. Scenario 3 is if they're only in zone 1, then you're looking at zygomatic, and if they're not even in zone 1, you can be quad zygomatic. My personal experience, so pinch of salt, but you know, a lot of the quad zygomatic ones over long term, and I've seen them probably over plus 10 years now, maybe even longer. Yeah, probably. You would need actually longer. Some of those don't really, they're not, you know, the way that you intended in that time, and you know, you need to make patients aware of this. There are other complications that you get with this type of procedure. So these are the zones that I was talking about, the 1, 2, and 3, where you've got bone in all 3 zones. Look, you've got good height, you probably go straight to fixture, and you can place all the implants that are required and to take the occlusal load. So this is the Bedrosian scale. If you're going, as I said, go back to what I was saying, this going back to our markers. So here we've actually got bone really in zones 1 and 2. In zone 3, we pretty much lost bone. Conventionally, if you wanted to do this conventionally, you would need to do subbilateral sinus lifts to get that level of bone. Depending on how much bone is lost there, you would then either need to have prosthesis direct to fixture in that midsection where you'd have some pink porcelain or pink around them minimally, and certain cases you'd be able to get away with longer teeth. However, if you have bone in zones 1 and 2, the best way to approach that would be to place tilted and straight implants. Again, our markers, that's only in zone 1, and this is where you basically have only the option of zygomatic bone grafting. You could, in this situation, do bilateral sinus lifts. In this sort of situation, I'd probably place 4 implants in the anterior region, and if I'm going to do sinus lifts, either 2 to 4 implants in the anterior region and 2 to 4 implants posteriorly. Non-tilted implants conventionally, because if we're going to sinus lift, I'd want to lift that entire sinus towards the back and take advantage of that. If you're in there and you're doing an invasive procedure, that's basically, you know, you may as well maximize on that. Okay, so that's the first part today of some basic principles within treatment planning. I hope you've all enjoyed the webinar. We will be back next Wednesday with part 2, where we'll be going a little bit more in depth into the planning and basement. I hope you all stay safe until then, and see you then. Take care, and bye-bye.